Hello, welcome everybody to the seminar series for today. Our speaker is Daniel Song, and he'll be talking about the occupational noise exposure and the risk of cardiovascular disease, diabetes, and rheumatoid arthritis. He's an SPPH MSc student, and thanks for attending.
Hello everyone, it's a great pleasure to be here to talk about my research. And my research topic is occupational noise exposure and the risk of cardiovascular disease, diabetes, and rheumatoid arthritis. I'll start with some background information. Noise is one of the most common hazards in the workplace all over the world. In Europe, 28% of workers can you turn down? Sorry. In Europe, 28% of workers are exposed to noise higher than 85 dBA. And in the United States, 22.4 million workers are exposed to noise of higher at a hazardous level. And in developing countries, the situation is much worse due to lack of effective control method. And a crude estimation of the population exposed to occupational noise in British Columbia ranges from 140,000 to 220,000. Noise exposure may cause loss of adverse health effects in humans, such as noise-induced hearing loss, fatigue, annoyance, psychological stress, elevated blood pressure, and potentially cardiovascular disease. Cardiovascular disease is a potential health effect of noise exposure, and relevant studies can date back to the 1970s. Although lots of studies have been done on this topic, there are still some controversies. A biological model is proposed to unveil the occupational noise exposure and the cardiovascular disease relationship. It shows a chain of reactions in the human body which connects the noise exposure and the health outcome of cardiovascular disease. A simplified version of the biological model is shown on the right side. In this whole process is an external stressor, just like physical exertion or sudden emotion stress. And the exposure will influence the function of the sympathetic nerve system and endocrine system. And this will lead to the change of blood composition and the hemodynamic disorder in human body, and which finally will result in cardiovascular disease. However, the effect of noise as an external stressor on human body is not specific. Therefore, a more general biological model may apply. The impairment of the sympathetic nerve system and endocrine system will influence in the inner balance of human body, and the impact of the disruption of homeostasis is not just restrained to the cardiovascular system. Other systems and their functions may also be influenced. For example, if the disruption of hormone secretion results in insulin resistance or hyperinsulinemia, diabetes might become the health outcome. Or if the immune system is influenced and results in inflammatory reactions in human body, the rheumatoid arthritis might become the disease outcome. However, the association between the occupational exposure and these two health outcomes has never been studied. And so given the background information, the objectives of our study was to first to build a job exposure matrix for using the measurements from WorkSafeBC's noise exposure dataset, and to develop the noise exposure estimates for participants in the National Population Health Survey using based on the job exposure matrix. And finally, to estimate the association between occupational noise exposure and the health outcome of cardiovascular disease, diabetes, and rheumatoid arthritis. And about the methods, Here I show a general process of the methods used for the study. Two datasets were used in the study. One is the WorkSafePC's noise exposure data, and the other is National Population Health Survey. The noise exposure data was selected mainly to provide the noise exposure levels by different job titles and industrials. And the study population was formed based on the subjects of the NPHS data. The NPHS data provides information on the subject's job title, industrial, exposure duration, disease status, and other lifestyle factors. According to the exposure level and job title and industrial, and as well as the exposure duration, the noise exposure of each subject was evaluated. And based on the disease status and the time of diagnosis, the health outcome was determined. And the smoking status and physical activities and other factors were used as the covariates. Finally, with the exposure health outcome and the covariates, the conditional logistic regression model was used to calculate the different odds ratios for different exposure groups. I'll start with the noise exposure data. The data source was from the POP data BC. The data was collected by WorkSafePC mainly for compliance reasons. So important information included in this data set are the sampling time and the sampling type, whether it's a grab sample collected using sound level meter or a personal sample collected using dosimeter, and the industrial codes representing the industrial of the sampling, and the job description showing the condition under which the sample was collected, and finally the exposure level expressed in dBA. In terms of the National Population Health Survey, it's a longitudinal survey established from 1994. It's conducted every 2 years. 8 cycles of the survey was used in our study, covering a period of 16 years. And the target population of the NPHS is the Canadian population during the 1994 to 1995. 16,276 subjects was selected based on the stratified multi-stage sampling design, and the data collection is conducted based on using the computer-assisted interview system, which allows the check of the logical flow associated with the questions being asked. This was designed to control the validity and consistency of the collected data, not within cycle, but also from previous cycles. So the quality of the collected information was monitored, and some potential errors was located and modified during the interview. In the first cycle, 75% of the subjects were interviewed in person, while the rest by telephone. In the following cycles, the telephone became the major interview method. So our study was a case control study based on the nested within the study cohort. Three cohorts were defined based on the subjects of the NPHS. One for cardiovascular disease, one for diabetes, and one for rheumatoid arthritis. Two inclusion criteria were applied, restricting people to those aged 18 to 55 and who didn't report the health effect of interest from cycle 1 to cycle 4. The study, all these subjects were followed from cycle 5 to cycle 8 to see the occurrence of the health outcome of interest. The cases were defined as the first time reporting diagnosed with the health outcome of interest. And once a case was found, 5 controls were randomly selected from those who didn't who didn't have the health outcome of interest at that time point. And the cases and controls are matched by age and sex. Before I move to the exposure assessment part, it is necessary to talk about the hierarchy of the North American industrial classification system and the national occupation classification for statistics, because the linkage between the two data sets were based on them. So here I use the NAICS code as an example. The NAICS code provided in the MPHS has 4 digits. The structure of the NAICS code is shown in the slide. The code at 2-digit level shows the information for a certain sector, while a 3-digit NAICS code represents a more specific subsector. The 4-digit NAICS code shows the information for a certain industrial group. The hierarchy of the NOx code is kind of similar, so I don't show them here. The information for the exposure assessment came from both the noise exposure data and the MPHS data. So I will start from the noise exposure data. The data cleaning process and the transformation process of the data set is complex and extremely time-consuming. But briefly speaking, the data cleaning was to check every observation to see whether it is useful. This process was done mainly based on the job description variable. For example, like in some observations, the job description variable just say the first floor or just a bracket. They're not able to provide useful information and got deleted from the dataset. The 4-digit NAICS code was assigned based on the industrial code in the original dataset, and based on the job description variable, a 4-digit NOx code was assigned. And after this process, the average noise exposure level was calculated at the combination of the 4-digit NOx and 4-digit NAICS level, the 4-digit NOx level, the 4-digit NAICS level, and 2-digit NOx level, and finally the 2-digit NAICS level. All these results were aggregated into a job exposure matrix. Here I show an example of the job exposure matrix. So from the table, we can see the noise exposure level for the saw filers in the sawmills was 87.2 dBA, while that for the saw filers in the wood product manufacturing industrial was 87.6 dBA. However, when we only considering the exposure level for the saw filer occupation, the level was 88 dBA. Another point I want to point out here is since the WorkSafe BC data is compliance oriented, only those occupations or industrials with higher chance of exposed to occupational noise were recorded in the dataset. So there are other occupations that have very little chance of being exposed. So they're assigned a 0 level and added into the job exposure matrix, which was highlighted with the orange color in the table. In the National Population Health Survey, the 4-digit NOx code and the 4-digit NAICS code and the working hours per week and the working weeks per year of each subject was provided in the labor force section. So the approximate working hours for each subject in each cycle was calculated. And as I mentioned before, the WorkSafe BC data only cover those jobs and occupations with a higher chance of being exposed to noise. However, the MPHS sample is a representative. However, the MPHS subjects is a representative sample of the Canadian general population, in which there are a wide range of occupations and industrials. Although the two datasets have overlap on the 4-digit NOx and NAICS code, there are still many other 4-digit NOx and NAICS code in the MPHS that cannot be found in the noise exposure data. And so within the overlapping area, the match of both the 4-digit NOx code and the 4-digit NAICS code was given the best rank of assigning. And if the match was not found, the exposure level was assigned first at the 4-digit NOx level and then the 4-digit NAICS level. And outside the overlapping area, those occupations which have very little chance of being exposed were given the zero exposure level first, and then the exposure level was assigned to the rest subjects, first based on the 2-digit NOx level and then on the 2-digit NAICS level. And through this linking process, 6 rings of assigning exposure level were generated, representing the confidence and the reliability of the assigned level. And so after this whole linkage process, all the subjects in the MPHS got an exposure level in each cycle. So now the exposure level and the exposure duration were all known. So the cumulative noise exposure was calculated using the formula shown in the slide. And the overall exposure period started from the first cycle and ended as the subject became a cases or control. And so, for example, if someone was diagnosed with cardiovascular disease at the midpoint of 2007, the whole exposure period was from the first day of 1994 to the midpoint of 2007. The noise exposure was calculated first within each cycles and then added together. And based on the calculated cumulative exposure, the three different exposure groups were defined. And there are other factors that may play the role as the noise disease association. Their effects were adjusted in the model, and all the information about these covariates was provided in the different sections of the MPHS. And in the table, I list those covariates I selected for the 3 health outcome of interest. And about the statistical analysis, the characteristics of the cases and controls was described using the cross tabulations. And then the bivariate analysis was conducted to check the exposure covariates association as well as possible collinearity among covariates. And to estimate the noise disease association, the conditional logistic regression was used, and the odds ratios for different exposure groups was calculated, and the model predictors was selected based on using the forward process, which is to start with only the noise exposure as the independent variable and the health outcome as the dependent variable, and then adding potential confounder or groups of confounders to see how they will influence the odds ratios. So I'll start with some results from the noise exposure data and then the MPHS data. So in the original data set, there are about 50,000 observations. All those samples collected from 1970 to 2004. The minimum and maximum value, the mean and standard deviation of the collected noise exposure level was shown in the slide. And there were 276 different industrial code and about 28,000 unique job descriptions. After the data cleaning and transformation, 15,000 observations left. The minimum maximum value, the mean and standard deviation didn't change too much. And there was 132 different categories of the assigned 4-digit NAICS code and 264 different categories of the assigned NAICS code. Since the decibel unit has been log transformed once, it is expected that it will follow a normal distribution. And based on the histogram and QQ plot here, you can say it's likely normal. It's reasonable to use the mean noise exposure level for the estimates. And this slide shows how the observations was distributed in each among different industrials and the average noise exposure in each industrial. The table is sorted by frequency. And from the frequency and the percentage column, we can see the distribution was highly skewed. About 95% of all observations was collected in the three industrial, the manufacturing, the agriculture, forestry, fishing and hunting, and the construction industrial. However, on the other side, even we go down to the industrial with very small percent of observations, like the mining, quarrying, oil and gas extraction industrial, there was still 89 observations. This is not a small number compared to some similar research. So we believe it can. It can provide a relatively reliable estimates for noise exposure by industrial. And about the means and standard deviations, we can see some large standard deviations in many industrials, and this is a signal to use the combination of the NOx and NIx code for to do the linkage for better estimation. The situations of noise exposure by occupations is kind of similar by industrial, and we can see higher exposure level in those occupations as we expected to see. The noise exposure level by occupation was not against our common sense. And the V8 exposure matrix, the noise exposure level didn't decrease too much during the past 30 years, which indicates that the time axis won't be necessary. Then I'll talk about the results from the National Population Health Survey. Since I'm still trying to explore some potential biases of the study, this might not be my final results. This slide shows the flow chart of selecting the cases and controls for the cardiovascular disease. After applying the two inclusion criteria, 7,193 subjects were left in the starter cohort for cardiovascular disease. And during the follow-up period, 221 new cases was diagnosed and 1,105 controls were selected for them. The characteristics of the cases and controls were shown in the slide. The p-values come from the Pearson chi-square test, and the value of less than 0.05 indicates a strong relationship between the disease outcome and certain factor. From the p-value and the distribution of cases and controls among different exposure groups, we can see a very strong relationship between the exposure and the disease outcome and the cardiovascular disease, and this we can see a strong relationship between the cardiovascular disease and the smoking status, drinking status, hypertension, as well as family income. this indicates that these variables need to be added into the model. And both the unadjusted odds ratios and adjusted odds ratios from the conditional logistic regression was provided in this slide. And after going through the full process of selecting variables, selecting predictors, the full model with all covariates was finally used. From the odds ratios among different exposure groups, we didn't see a significant, statistically significant association between exposure and cardiovascular disease. And after adjusting for covariates, the association became weaker. And the association between the cardiovascular disease and the smoke status and the hypertension was in our results. We find that smoking and hypertension will increase the risk of getting cardiovascular disease. This is also finding in other previous studies. And in terms of the diabetes, 202 new cases was diagnosed during the follow-up period, and 1,010 controls was selected for them. The characteristics of the cases and controls were also shown in this table, and the distribution of cases and controls among different exposure groups is very similar, which indicates the noise diabetes association can be very weak. And the strong association was found between the diabetes and obese status, physical activity, drinking status, hypertension, education, and family income. And all these variables are added into the statistical model. From the results of the regression, we didn't find statistically significant association between noise exposure and diabetes. And after adjusting for covariates, the direction of the association changed. However, it's still not statistically significant. And a strong positive association was found between the obesity status and the cardiovascular and the diabetes, which is also found in many other studies. No statistically significant results was found between association was found between diabetes and other covariates. And for the rheumatoid arthritis, 91 new cases was diagnosed during the follow-up period, and 455 controls were selected. The p-values and the distribution of cases and controls among different exposure groups also shows a very weak relationship. The strong relationship was found between the rheumatoid arthritis and the education and the family income. And from the results of the regression model, it also shows a very extremely weak association between occupational noise exposure and rheumatoid arthritis. And after adjusting for covariates, the direction of the association changed, but it's still not statistically significant. And from the results, we can also see that people who have moderate physical activities and who have higher family income are less likely to have the rheumatoid arthritis. So according to the results we didn't find any statistically significant positive association between the occupational noise exposure and the three health outcomes of interest as we hypothesized. So since I'm still trying to finding out some potential biases from the study. Instead of making conclusions, I like to discuss some possible biases and limitations of the study. Many previous studies have found a positive association between occupational noise exposure and cardiovascular disease, but there are also other negative ones in which no statistically significant results was found. And here I list some of these studies, and I want to highlight the exposure assessment method used by this study because it's a very important part in occupational and environmental epidemiological studies. In general, 3 exposure metrics was used. The first is the self-reported exposure. This one is more like a qualitative method based on questionnaires, so it can be very subjective. And in previous studies using this method, both positive and negative results were found. And another one is to calculate the exposure duration above a certain threshold. This one is able to quantify the noise exposure, and in some previous studies, the strongest association was found when using the 85 dBA as the threshold. And the third one is the cumulative noise exposure, the one I used in my study. And this one is also a quantitative method. And in studies using both the exposure duration and the cumulative noise exposure, the stronger association was found when using the exposure duration above threshold. The biases may come from the exposure assessment part, as well as the measurements of health outcome. Since the disease is all self-reported, there could be potential misclassification. However, because the disease covariates association looks quite fine in our results, this might not be the major concern in our study. And so this problem may still come from the exposure assessment. And I chose the cumulative noise exposure considering the availability of information as well as the feasibility of using the metrics. And as I mentioned before, the cumulative noise exposure tend to underestimate the association. And another problem could be the missing values. In some MPHS cycles didn't provide the NOS and NIX level as well as the exposure duration for some subjects. These gaps were filled using all information available. And when I tried running the regression within subjects who didn't have missing values, and this didn't change the odds ratios very significantly, which indicates the missing values might not be a big problem in the study. And as I mentioned before, there were different ranks of assigning the exposure level, and we believe the exposure level assigned at the 4-digit level can provide a better estimation. And when I run the model restricted to subjects whose assigned rank ranged from 1 to 4, the association between noise exposure and disease and the outcome of diabetes and arthritis became stronger, but still not statistically significant. And another problem could be the healthy worker effect. People who have jobs are healthier than those who don't have job, and these people are more likely to be exposed to noise and less likely to have the disease outcome. And there are also some limitations of the study. And we were only able to evaluate the noise exposure level from the in the workplace. And however, the noise exposure exists almost everywhere in our daily life. So what we capture in our study is just part of the total noise exposure. And it is also indicated in some studies that the noise exposure may have joint effect with other factors like the air pollution and job strain. This association may become stronger with the existence of other factors. And because we didn't have relevant information on these factors, we were not able to consider the joint effect in our study. And finally, another limitation is we didn't consider the influence from wearing the hearing protectors. And because the NPHS didn't provide the information on this, and in some previous studies, a more significant exposure response trend was found when using subjects who didn't use the hearing protectors. And this indicates that the true association might be distorted by this factor. And so I guess before I make any conclusions from our study, I still need to do more research on the biases of the study. So that's all. And finally, I want to thank my supervisor and thesis committee, and Nikki and Melissa, and Karen and Lee from the Research Data Center of UBC. I also want to thank WorkSafeBC and the Bridge program for the funding. And thank you so much.
Hi, thank you so much, Daniel. That was really interesting. I guess just a little bit more information on your background, rationale for looking at cardiovascular disease, diabetes, and arthritis. Pardon me. What was the rationale for looking at those three diseases and not just cardiovascular disease? And you might have mentioned that, but clarify.
Can you repeat your question, sorry?
Thank you. Sorry, probably not clear. You might have mentioned this, but it's still a little bit hazy for me. What was the rationale to choose those three health endpoints to look at for cardiovascular disease? I'm not sure I quite understood why those three diseases were chosen in particular and not just cardiovascular disease. Like why you chose the three health outcomes.
The three health outcomes?
Yeah.
And I chose the cardiovascular disease first selected because many studies have been done on this, and there are still some controversies on the topic. So I want to use the NPHS as which has a representative of the general population, to find whether the association can be found in this in this population. And about the diabetes and arthritis, for the diabetes, because in some studies, the biological model shows that the stress caused by noise will result in the insulin resistance or hyperinsulinemia, and these are the other reasons to cause the diabetes. And for the rheumatoid arthritis, because the immune system the effect of the immune system can also be influenced by the stress caused by noise. So I just choose the rheumatoid arthritis.
I was going to ask you something about one of the earlier stages of your work when I think you're transforming job descriptions and giving them NOx codes or something like that.
Yeah, NOx code.
I mean, that seems like a challenge in itself. Did you have to kind of become familiar with a lot of different industries to say no that a saw filer was the same thing as a saw repairman or anything like that?
Yeah, because I need to know the meaning of those jobs. Then I can categorize them into the right then I can give them the right code. So I did a lot of background study on those industrial codes and the occupation codes. Yeah. Yeah.
On slide 25, you showed a list of job descriptions, job categories with the noise stats. Not sure it's exact. Yeah, that's probably it, that one. Previous one. Previous one. That's it. So the category with the highest mean noise exposure of 92 is education services. What does that mean? Who are those people? And why are they exposed to so much noise?
I'm not sure I have the right answers for this now, but one explanation could be there's some technical or trade schools belong to this category, which may result in this higher exposure. But I'm not sure about that. And because we found this in a and this indicates that the NOx code might be a better might provide a better estimation compared to the NAICS code. So when we do the linkage, we give the priority to the NOx code compared to the NAICS code.
I have one question from the online audience. It's from Dave Keenan, and he wanted to know what the threshold, criteria, and exchange rate you used was. What is the threshold, criteria, and exchange rate that you used for your summary?
I think in our study we didn't use the threshold because we use all the exposure. We use the mean noise exposure level from the job exposure matrix, and there is. I don't think there is a threshold being used in our study. And for the exchange rate, I think the 3 dBA exchange rate may apply.
Hi, Daniel. So, I'm a big fan of using the Statistics Canada survey data in general, and I think they're underutilized. And I think you've done the best possible job you could do to develop a job exposure matrix with which to conduct an occupational health study using the StatsCan data. So I'm interested in your thoughts on whether we should be using this data for occupational health studies, given what you found. And I know your limitations are specific to your study, but do you think they persist for other occupational studies, and that we just can't use these data to look at exposure and disease relationships for occupational health?
So I think at the current stage, I think in the designing stage of this study, we expect to see a positive association between occupational noise exposure and cardiovascular disease, and use that as a sensitive indicator to see whether the population data can be used to test the noise disease association. But now I think, even for the cardiovascular disease, there is no statistically significant positive association was found, but we're still trying to explore potential biases. And I think at the current stage, I cannot make a conclusion to say whether in future study the MPHS is a very good source to SM for the occupational epidemiological studies.
I was just wondering how much literature there is actually on the link between noise and cardiovascular disease, because you showed some papers, some relevant papers. Is there a large body of evidence, and are there any like meta-analyses, systematic reviews that really kind of weigh all the studies together yet?
You want to say like the number of papers I find, or I think there are lots of papers on this topic, and there are also like meta-analysis or systematic reviews, and in some meta-analysis, they suggest they still find controversies among different papers. So I think most results from the studies will show a positive association. In some very small number of papers, still didn't find any positive results. I'm not sure.
So, thank Daniel. Daniel, thank you so much for your presentation.